Hi, welcome all to the presentation. In this presentation, we're going to discuss about a very commonly discussed topic in recent days, that is mucormycosis, which is otherwise called as the black fungal infection in recent days of this COVID era because of decreasing immune mechanism of human as well as increasing prevalence of these fungus in the environment. So we will, in this presentation, we will see on what is exactly causing this mucormycosis and what are all the clinical features and the symptoms that you can observe and how do you prevent them. So this mucormycosis is otherwise called as zygomycosis, and from the word myco you can understand that this is being caused by a particular fungus. We call this as an opportunistic fulminant fungal infection. Why do you call something as opportunistic? Is opportunistic means making use of the prevailing opportunity or the prevailing environment it makes use of, because these microorganisms, if you see interestingly, are prevalent all over in the environment of spores, but they are not harming the human being as such. Only when the environment, when the host environment is favorable for their growth, they are making use of the opportunity to grow inside the human and produce the clinical symptoms and the signs. And it is also called as fulminant because it follows a very short duration and it's very acute and highly destructive. In a given very short span of time, it is able to cause a massive destruction in the human being. That is why it is called as opportunistic fulminant fungal infection. Once again, why it is called as opportunistic is in a normal host mechanism, it is not able to cause this destruction. But when the host environment is such that favoring the growth of the organism, it thrives, multiplies rapidly in the host environment, and it is capable of causing a massive destructive disease. That is why it is called as a fulminant fungal infection. The organism which is causing the zygomycosis or mucormycosis is called as zygomycetes. It is liberated as spores throughout the air. In the normal environment, in the air, whatever we inhale, these spores are liberated and it is entering into the human body. The portal of entry into the human body is via inhalation. That is, it is finding the route of entry to the through the nasal passage. Okay, so from the nose, because of its close association with the cerebral cavity, it is capable of spreading onto the brain as well, and it is capable of causing fatality to the patient. So these spores are liberated throughout the air and inhaled by human being, and when they are inhaled, they do not survive much in the uh, human environment because of the host defense mechanism. Only when the defense mechanism of the host is hampered due to any immunocompromised state. Usually earlier we used to have this mucormycosis much prevalent in diabetic individuals, type 2 diabetes mellitus, who will have ketoacidosis because this needs serum iron. The iron is a very important source or nutrition for these microorganisms to grow. So they were earlier seen only in immunocompromised state like type 2 diabetes mellitus. But nowadays, due to increasing COVID situation in patients, post-COVID patients who are recovering from COVID, when the immunity is suppressed in them due to excessive usage of corticosteroids and the viral organism as such, this fungal organism is found to be more prevalent in recent days. And the rhinocerebral form is most relevant. As I have told, the portal of entry is through the nasal passage, and it has got a very close association with the brain, and it is capable of penetrating the cranial vault and spread into the cerebral cavity. And this is most commonly noted in insulin dependent diabetes patients and other immunocompromised patients. So we'll just see what is the exact pathogenesis or pathophysiology that is being involved in the development of this mucor species. So you're seeing a picture of a normal host cell and a susceptible host. Susceptible host means a person who is likely to develop this infection. So in a normal host, though this organism enters into the human body, it is not able to survive. Why? Because to cause the disease, the agents of the mucormycosis must scavenge from the host sufficient iron. It should derive the sufficient iron for its growth from the human being, and it must evade. First, it should grow. For that, it needs abundant supply of iron. Then, it must evade or invade the host phagocytic defense mechanism. You know something called as phagocytosis, which is a cell eating mechanism. That is, our body will be able to scavenge the foreign material that are entering into the human body through the inflammatory cells present, and these microorganisms should be able to invade into the host phagocytic defense mechanism and must access. Once they enter, they need nutrition to survive. So where do they derive the nutrition from the vasculature of the human body. So they should gain access to the blood vessels. But in a normal host, all these are not happening because the primary defense mechanism itself is reduced serum supply to the organism, so it is not able to replicate. Even if it replicates, it is phagocytosed by the circulating neutrophils and the tissue macrophages. These cells will engulf the fungal organism and phagocytose it, and then the endothelial cells. In normal healthy individuals, the endothelial cells do not permeate, or they are non-permeable for entry of, they are intact in maintaining the integrity of the blood vessel, and these microorganisms are not able to invade into the blood vessel, so they are not deriving the required nutrition also. But vice versa, in a susceptible host, for example, a host who has got an immunocompromised state, as in like your diabetes ketoacidosis, what happens is there is increased serum iron level, which is causing an increase in the, which is favoring the growth of this microorganism. This causes rapid fungal growth and defect in the phagocytic defense mechanism and deficiency in the number of neutrophils, which is called as neutropenia. All these are favoring the growth of this fungal organism, and finally this fungal organism is able to adhere to and damage to the endothelial cells, because the fungal angioinvasion is very much capable in immunocompromised patients. It is invading into the blood vessels and causes vessel thrombosis and subsequent necrosis, and from there, from the blood vessel, it is disseminating to various organs and it is capable of causing mucormycosis. So what are all the clinical findings you will be able to observe in mucormycosis patient? The first and foremost is being the nasal obstruction. This is the early sign. The patient develops nasal obstruction as soon as the fungal organism enters into the through the nasal cavity, and you will be able to observe bloody nasal discharge and facial pain or headache, and sometimes it may even lead to facial swelling or cellulitis. When it is when the growth is enormous and it is involving the orbit, there will be some amount of visual disturbance as well. You can see here in this particular picture, you can see how extensive is the growth. It does not occur as a normal ulceration, but rather the ulceration is much more rapidly spreading, and you can see, unlike other ulcers, the area becomes completely blackish in color due to necrosis. So with the cranial vault involvement, when the cranial vault is getting involved, it is capable of spreading into the eyes and causes blindness. And also when it invades the cerebrum, it is capable of causing lethargy and seizures, which is ultimately followed by death. If the maxillary sinus is involved, the swelling may rapidly spread into the palate, because it is not through the oral route that microorganism is entering into the human body. But when it is entering into the nasal cavity and it is involving the maxillary sinus, there are chances that your intraoral swelling may also be observed in palate as such blackish discoloration. Here you can see an extensive black necrotic lesion of the palate, which represents a zygomycotic infection that has probably extended from the maxillary sinus in a patient with poorly controlled type 1 diabetes mellitus. If it is untreated, it may lead to palatal ulceration, and the surface of the ulcer will appear black and necrotic, and there is massive tissue destruction. So what can you expect on a radiograph? When a CT, computer tomograph, is taken, you can observe opacification of the involved sinus in conjunction with patchy effacement of the bony walls of the sinus. You can see the opaque area here, which is representing the involvement of the maxillary sinus by the mucormycosis species. So histopathologically, what all you can expect? When you do a biopsy from the involved site, you can observe extensive necrosis. Unlike normal chronic inflammation, there is extensive necrosis with large number of 6 to 30 micrometer thickness hyphae. These hyphae are very thick. Out of all the fungal infections like your candidiasis, aspergillosis, this is one of the largest hyphae and thickest hyphae, and it measures roughly between 6 to 30 micrometers in diameter, And this hyphae is a branching hyphae, and you do not have septae on the hypha. The body surface does not show any divisions. It is a non-septate hyphae, and it has got a very unique feature of 90-degree branching. That is, the branching of the hyphae occurs at 90-degree or at right angles. There is extensive tissue destruction, which is due to fungal invasion into the smaller blood vessels, and this fungal invasion will disrupt the blood flow, which is resulting in infarction and necrosis. You can see lot of neutrophilic infiltrate in the tissue as well. So this is a picture which is showing presence of the fungal hyphae. You can see large hyphae distributed here. You can see how thick the hyphae are. It is not slender as how you see in Canada species. And here you can see the branching. The branching is typically occurring at right angle. It is almost like a 90-degree branching, and the body surface, the hypha, is not showing any divisions. That is why we call it as a aseptate hyphae. So So you will have to confirm the diagnosis of mucormycosis not only based on clinical features but also on histopathology, which is found to be the final guideline in giving you the diagnosis of mucormycosis. Once this disease is diagnosed, usually the prognosis is very poor in mucormycosis patient because of the rapid spreading nature. And how do you treat the patients with mucormycosis is by radical surgical debridement of the infected necrotic tissue, and you will have to systemically administer antifungal agents like your amphotericin B. The underlying immunocompromised state should also be kept in control, and when you are doing a radical surgical debridement, it is going to leave a void. So in order to compensate for this, prosthetic obturations can be designed to fill in the defects. So I hope this presentation would have given a slight light into what is mucormycosis, what is exactly causing, and why there is a sudden increase in the prevalence rate of mucormycosis in the recent past. Thank you for watching.